The care team developed initially through another psychologist and I just sitting in what they call the high-risk OB meeting. So we develop a list that we review every week of patients in pregnancy that we consider high risk. And those high risk patients can be just due to medical issues or psychosocial issues or chemical dependency issues. So it really started there and kind of talking with the providers about how we could interface with those high-risk patients. We started seeing patients in the family birthing unit, and those calls can be a variety of different things. It can be a traumatic birth loss. It could be concerns about bonding with, maternal-infant bonding. It could be a depression that kind of just surprise popped up out of nowhere. It could be social issues and not going home to a safe place. And then, since then we've remained on call for inpatient service and we try to follow our patients through the entire birth process. The flow of my day in women's care is really different than it is in primary care. Primary care, not that it's a specialty practice and so, you're not holding on to these patients like you do in family care, but basically the day starts at 8 a.m. and I'm usually, it's scheduled and back to back and could be, it's very unpredictable. You don't really know what you're going to have come through the door. You don't really know what's happening at the family birthing center. You don't really know. So as a practitioner in this setting, you pretty much have to be a person that can really flow with the stream of the population that's in the clinic that day. For a behavioral health provider, especially if you've worked in a medical setting like primary care, this is a specialty practice and it's really important that you're aligning your efforts around the specialty practice. So it's not uncommon. So, obstetricians usually have a 6-week postpartum visit and then they don't usually follow them unless there's good reason to. And so that can be something that you have to work with as a team on how you're going to manage that. Some people are coming into specialty practice on one visit for a consultative practice on the GYN side of things, and you may never see them again. So you have to tailor each visit as though it's going to be your last. I think there's a lot of education in engaging with women in women's health because sometimes I'm not seeing them for a mental health issue. For example, I had a patient that was starting to have her blood pressure creep up to a point where we potentially could have had to put her on bed rest or on medication throughout her pregnancy. And we know through our research that consistent behavioral interventions can help prevent that. And so she was really surprised to see a behavioral health consultant to help her through that. But gladly, once we got through that education phase of that nobody thinks you're crazy because you have this going on, that we're really trying to provide you with the best service to support your health through your pregnancy. We were able to prevent her from getting on medications, and we were able to prevent bed rest, which is not very fun if you're pregnant. So I think just again, having some patience and a willingness to teach is probably the best position you can be in. Some of the challenges we see in women's health are women, especially pregnant women, are really afraid if you detect a mental health issue or a substance use issue that you're going to alert the authorities that they're an unfit parent and that you are going to suggest that we remove the children from their custody. And that is not a small fear or barrier. There's a lot of assurance that goes in with working with women in this population. To be fair, of how women have responded, I think it's kind of a mixed bag. I would say for the most part, women are very excited to have somebody that's readily available that they can see side by side with their doctor. And there's just some women that are disenfranchised from the mental health system altogether, and no matter what they have going on, they're not willing to engage even though I'm right there. And so, but I would say the preponderance are happy that they're able to access complete holistic care at the point of care in which they're going. I really believe in two things, is you have to build your relationship with the providers. They have to know they can trust you with their patients and that you have the knowledge and skills to guide their practice. So everything starts with the relationship. And then that's where the work really starts to begin, is that you can kind of start reforming practice change based on you earning your credits with each provider. Integration into women's health is really hard work, and it's very, very rewarding. I don't know that I fully appreciated the full weight of the work. You're not often dealing with one, you're dealing with two. And what you do with the one impacts the other, the neonate and the life of that person going forward. And that's, it can feel overwhelming, and that can feel really exciting at times. But from what I can see, women that are really willing to engage appreciate the effort and are motivated to make the changes. And that makes the work really worth it. And the providers welcome the support because they want a good outcome for their patients and the babies as well.